Welcome to Mic'd Up with ChiroUp podcast, where I'm your host, Brandon Steele.
And I'm your co-host, Tim Bertelsmann.
And you're tuning into the one and only evidence-based podcast made by chiropractors and for chiropractors.
Here's how it works. We'll have a new clinical topic that we dive into each month, and you'll leave with practical skills that you can apply right away.
Well, that's contingent on who's giving the advice, and you'll want to take mine.
Let's dive in.
Welcome to the next episode of Mic'd Up with ChiroUp. You've got Tim and Brandon today, and this episode is going to be a little something special. We're going to talk about shin splints. We're going to talk about going to chiropractic college. We're going to talk about degenerative meniscus tears and a little bit of insights in shoe wear for those runners out there. And then, of course, we're going to go through a little bit of an update on our EMR that we believe is going to really have an impact on the profession. But before we get into that, I really want to encourage you to follow this episode, follow the show, review us. We really appreciate the ability to talk with more providers out there and get feedback. In fact, I want to thank Dr. Thompson for the question on medial tibial stress syndrome, or Shin Splints, which we're going to cover in today's episode. So we take that feedback and we turn it into an episode and hopefully turn into something that is going to help with patient care, hopefully by the next day. Now, it's getting warmer out here. It is April in the Midwest, which means people are getting outside, people are getting more active. So I thought shin splints would be a really good episode for today. We take those weekend warriors who have been sitting around cooped up all winter, and now they're becoming a little more active and, of course, ending up in our office. So this podcast is going to focus on a little bit of a seasonal injury. I know that we'll be listening to podcasts throughout the year. However, keep that in mind. Before we do that, though, and take a deep dive into to medial tibial stress syndrome, let's dive into a couple little fun topics first. And I guess I have to welcome back Tim. It was such a good episode last time without you, but welcome back to the podcast.
Hey, well, I appreciate the warm welcome. Thrilled to be back. And glad that you muddled through the last couple of podcasts without my clarifications. But I'm back to put all the puzzle pieces together. So for any confused listeners out there, we'll put it all back together at this point. I just want to know, were you able to get through the whole podcast without hitting the helium again? And if I need to remind you about that, or remind the listeners back from podcast 7.
Well, unfortunately, I'm getting dizzy at this point.
Yeah, helium's not good for you.
I forgot what episode that was.
That was cervicogenic vertigo, one of the best episodes, and I think it was probably one of the more popular because you were hitting the helium.
It's so funny that I walked in the office today and you were chuckling, and I was a little worried. I was like, "What is he listening to? What's he looking on his computer?" But apparently that was it. Let's get through one thing that I think is very interesting. And as a father of 3 children, they always have those questions of, "Dad, what do you do for work?" or "What should I do when I grow up?" And the reason I find that so interesting is that as someone who went to chiropractic school and went to undergrad, I think that I have a question for you, Dr. Bertelsmann, because your son is going to chiropractic college and he just started. So here's a question on the fly. In 30 seconds or less, convince a young college student to go to chiropractic school. So what was that conversation like for you and Tim Jr.?
First of all, I get time limits now. After that intro, you put me on a quantification.
That's 10 seconds.
That's 10, so I got 19 to go. I think the biggest thing is we always tell our kids to do something that you enjoy. And I can't imagine doing anything more that I enjoy. Of course, yeah, we all go to work and there are hassles that we deal with. But at the end of the day, we're using our hands and our words to make a difference in somebody's life. That's quite a reward. And we get physical and mental exercise during that process. And we feel that we're constantly needed and really hopefully appreciated by most patients. So if you don't enjoy those things, it's going to be hard to find any profession that you do enjoy. I like that. I love the continual challenges too, because our scene changes. Even in those of us with ADHD, we get a different scene every few minutes and a different problem to solve. That it's a puzzle all day long. And I think most importantly is I really do believe our profession's on the launching pad. That big data is here to stay, and big data is making every practice, regardless of what profession you're in, going to be practicing in a glass house. Everybody's going to see what you do, what your results are, what your patient satisfaction is. And there's not a profession in the world who can beat us on those. That our future is bright when the truth is out and everybody can see that. Do I have 2 seconds?
No, that was nowhere near 30 seconds. I was going to start searching for like that music that starts to play during a award ceremony. No, that's a great answer. I think that looking back at it, I was trying to think about my response to that. And I think that it's such an interesting thing when someone asks me, what do you do for a living? I say, I'm just a problem solver. And I think as a chiropractor, we have that.
You said solver.
Solver, yeah.
Okay.
Is that we have that ultimate autonomy to help people, which is really cool. And I like what you said about having that equal parts, mental, helping people and diagnosing people, but also athletic. It's a physical job. So I do appreciate that. I think that the number one thing that I would tell my son is that it is the ultimate guide to empathy, because it doesn't matter what you're feeling that day. It doesn't matter if you're tired. It doesn't matter what's going on in your life. Other people have problems and they're coming to you for a solution. And so I think that it's one of those really cool professions that helps build, once again, the mental, the psychological, and the athletic parts that are sometimes difficult to develop when you're sitting behind a desk all day and doing, accounting or whatever. Not that there's anything wrong with accounting, but it's a very different profession.
Yeah, certainly. It, like you said, the athletic aspects of it can wear bodies down, which takes us into the new research alert. And one of those dives is degenerative meniscus tears. That in the ChiroUp research section, we've got a number of providers who give us great articles. And I learned a couple of things from this article. That number one, we knew that conservative care works, but now JAMA said, yeah, that's exactly it. That conservative care, including exercises for 4 to 6 weeks, is the solution for most meniscus tears, with the exception of severe ones. That if you have a bucket handle tear that has some displaced fragment, that's probably one that needs surgery. If you have a young kid who's damaged their meniscus, they still have some blood supply. It didn't go away yet until they're 18 or so. It's something that may need surgery. But for most tears, which are degenerative, think of it as a rubber gasket that's laid out in the sun for 50 years. That's going to break down. It's going to start to fleck apart. It's going to start to tear. And in those cases, rarely is surgery needed. In fact, 6% of patients over the age of 40 with a meniscus tear are going to need surgery. And I think one of the most interesting things is that pain is not necessarily related to where the actual structural defect is.
Now, this is an opinion. I looked for this fact. I mean, I really did. I went and tried to find out this, because I know this to be true. However, after I said that, someone's going to turn around and prove me wrong. However, I always have thought that people with meniscus tears, the most common is that anterior medial meniscus. There's no question about that. However, one of the peak symptoms is actually the posterior lateral part of the knee, which is interesting because if you have a problem at the front middle part of the knee, why are we getting pain at the back part of the knee? I don't have the research behind that. That's a Brandon opinion, which I guess take it for what it's worth. But it's an interesting thing because the patient will come with back knee pain and you look for a meniscus problem. Anyway, the research article I picked out was actually on shoes. Thinking about people with medial tibial stress syndrome, I thought to myself, these people probably are in the wrong kind of shoe. And kinds of shoes are not determined by where you buy, meaning Nikes are different. They're different based on buying them from Kohl's as compared to buying from your local running shoe, but they're also different between types of shoes. And, as far as Nike, you can have motion control shoes, neutral shoes, cushioning shoes. And I think that's an interesting piece because we'll get a lot of people with running with knee pain. And one of the things with knee pain is that there is a specific type of shoe that will actually lead people into having that kind of pain. And those are people with high drop shoes, meaning people with a big heel counter, a lot of cushioning in the heel. And unfortunately, when you do that, when you have almost a slant forward with your shoes, it does put that patellofemoral joint and does increase the stress there. Now, it doesn't matter if you have Nike or New Balance or Saucony or whatever you're looking at. They all have these kinds of shoes. Don't look at telling your patients to only wear New Balance. They have to actually look at what drop shoe. So a zero drop shoe is when the back of the shoe and the front of the shoe are exactly the same. And then you can have a low, mid, and then a high drop shoe. But a high drop shoe, the one we're talking about, are the plus 8 millimeters, and you can find these numbers. It's not a secret at all. However, if you have someone with a high drop shoe, unfortunately, they normally do hit with their rear foot strike, and that will increase the knee ground reactive forces. So something else to think about when you have people with plantar fasciitis, Achilles tendinopathy, calf injuries, look at their shoes and make sure it's not a high drop shoe, because if you can take them to more of a zero drop shoe, it'll force them to go to a more of a midfoot strike and may help take away that, that problem that you're looking to solve. I saw Dr. B put on here, your Skechers Max Cushioning Elite shoes. And what are the big ones? The Hokas. So it's these different shoes, and they all have utility. So I'm not saying these shoes are good or bad. However, if I had someone with Achilles tendinopathy or with patellofemoral pain syndrome, and they were in a Skechers Max Elite Cushioning, that's a 16 millimeter drop. That's a big drop. So someone who maybe with walking, that's actually pretty good for them, but with running, it may be leading to their problem or at least contributing to it.
Yeah, a lot of things to think about. We've summarized some of this information in infographics in the forms library. So subscribers can jump into their forms library. You can look at a couple infographics on shoes, choosing the correct athletic shoe. Do you want one that is more neutral or one that's more cushioning? And then when you replace the athletic shoes, that people don't realize, especially runners, put some miles on those shoes pretty quickly. In 300 to 500 miles, that shoe needs to be replaced. So things that you can share, as well as a couple of running infographics on healthy running and running mechanics of how do your arms move, how are you supposed to hold your head, and what position is your chest. So all of those things are detailed. Check them into, and I think you'll appreciate those for your patients and social media followers. Now, the condition of the day, what you've been waiting for, medial tibial stress syndrome, or Shin Splints. What is it, Dr. Steele?
I have no idea.
That's going to shorten this podcast a whole lot.
I thought all shin splints were kind of the same, and it turns out I was wrong. This is one of those things that when you get that pain in the lower leg, between the knee and the ankle, and most of this pain, when the patient comes in, they just put back on their calf. However, if you kind of take your thumb and go right along that posterior medial board of the tibia, it hurts. And it's not one spot. You don't poke on it, it's a trigger point. It's going up and down that tibia. And shin splints is kind of a bad way of looking at it. I mean, everybody thinks that's what they have. However, this is really a prevalent condition. A third of the population of people in the athletic realm have this problem. And it's approximately responsible for 15% of all running injuries. So it's very, very common. And it's usually one of those things associated with going from sitting around all winter to now having to do, practice in high school, 5 days a week. But really what's happening is we're getting that repetitive, eccentric contraction of the deep flexors of the ankle. And unfortunately, when you're running, when you're jumping, or any kind of impact loading, you're really loading this tissue, and it's starting to actually pull away from the bone. When you look at muscles that have very short tendons, unfortunately, those are our torque muscles. And you're taking muscle almost directly to the bone, and there's not a lot of elasticity or compliance built into there as compared to like an Achilles tendon, where that tendon's going to absorb some of that load. So you have a muscle essentially pulling directly on the bone, and unfortunately, we start to see some underlying pathology.
Yeah, a lot of people think of this as just growing pains. Oh, we have a youngster whose shin hurts. It's probably growing pains. Well, a couple of years ago, the British Journal of Sports Medicine looked at 56 other studies and said that there really is not a relationship between growth and pain. And their conclusion is there is no association between maturation, growth, and musculoskeletal condition. So they really debunked the myth of growing pains, that when kids have pain, that's not normal. What's happened in shin splints is that there's repetitive traction on that tibia, which is causing myofascial strain and eventually periosteal inflammation. Well, once you get periosteal inflammation, you're starting to move into a bony stress reaction. So that stress on the bone, that anytime we stress it, the bone's going to remodel. If that stress exceeds the bone's ability to remodel, now it starts to break down, and that's really what's happening in shin splints, that this is not a benign condition of growing pains. It's not a benign condition where there's a little bit of tendinopathy or some muscular irritation. It's a precursor to a stress fracture, that if you continue to stress that bone, it's going to move forward. So a lot of people now believe that shin splints are just the continuum of stress on a bone that ends in a stress fracture. And it happens because of the terrible twos. There's too much, too fast, too long. Anything that somebody did to break the 10% rule that we often tell our patients, that your body can adapt to anything. If you want your bicep to be stronger, gradually challenge it. If you want your skin to be tougher, gradually challenge it. And if you need your bone to be more dense and more stable, it needs to be gradually challenged. When kids or adults jump into activity too quickly, something's going to give way. Whatever glass is closest to overflowing in that kinetic chain is the one that's going to overflow with symptoms. And if it happens to be the tibial border, it's going to turn into a shin splint and eventually a stress fracture. And certainly anything that amplifies that, poor techniques or increased activity, produce greater risk. But we also know that females have 2 to 4 times increased likelihood of progressing from a shin splint into a stress fracture. So we really want to be careful with those. And we'd be careful when a patient comes in with what symptoms.
What's interesting is that looking at kids when they run is you can almost predict these kids. Unfortunately, these kids have a lot of a medial heel whip, so they get a lot of twisting when they're running. So something to look for, along with that crossover gait when the feet are too close, almost running on a line essentially. But the clinical presentation of any kind of shin splints is starts off as more of a vague, diffuse pain over the middle to maybe the distal part of the tibia. This will normally be at the very beginning of activity, and then as they keep on doing the activity, it actually gets worse. So sometimes when things start to hurt, like plantar fasciitis, hurts worse when you first stand up, and then it starts to actually get a little bit better throughout the day. This would be a little bit different. It's a different tissue. Initially, symptoms may subside during training. However, as they start to not take care of it, and as they go through their season, as the condition progresses, symptoms are going to start to not only be there during the activity, however, when we start to do a lot of damage, it's even going to be there at rest. And that's when we really want to make sure that we can get these people a little bit of rest time. Any kind of pain that persists more than 5 minutes post-activity, that's a problem. That's kind of telling us we have a chemical reaction. We have a different kind of reaction. It's not just when you're using that MSK tissue, it's now lasting or lingering. So something we want to take into consideration. Also, numbness and paresthesia. This is one of those things that when someone's had this for a long period of time, the muscles are getting really tight and taut. Unfortunately, we have other things that live in that compartment, like nerves, like blood, and unfortunately, we can start to migrate into an exercise-induced compartment syndrome.
Yeah, so what we're looking for is we're going to apply the basics of every orthopedic test. Remember, every orthopedic test has a special name, but we can break it down that they do one of 3 things to a given structure. They push on it, they pull on it, or make it work. So what we're going to do is we're going to push on it. Just palpate the posterior medial tibial border. And what we should feel is a diffuse tenderness, like Dr. Steele said earlier, 5 centimeters. Not something that's real focal, but something that's at least a few centimeters long. Sometimes it often feels rough or bumpy when you dig your fingers into that posterior tibial border. We also can put a tuning fork over the top of it, that when we have elicitation of pain, that's 75% of cases are going to show that there's some sensitivity there, especially as we start turning into a stress fracture. And then have the patient hop, that again, this is the midpoint of a spectrum from a healthy tibia to a fractured tibia. So stress syndrome patients are going to have some discomfort about half the time when they hop. Now, when you move into a stress fracture, it's going to be, closer to 70 to 100% of the time, depending upon how pronounced that stress fracture is. And then one more thing we can do to stress it or make it work is the Taylor bump test. Just whacking on that patient's heel and saying, does that hurt? That should do nothing to somebody who has purely shin splints, where there's muscular irritation. But once it turns into some periosteal reaction that then starts to migrate into the bony stress fracture, that's not going to feel good. Those are the things that we're primarily looking for. Yeah.
This is a little bit off topic. However, I know, is that one thing to keep in mind with this area of the body is that you can actually have a fracture, whether it's a stress fracture and actually a full fracture of the fibula and still walk on it. So that is a differentiating thing, is that the tibia, when you fracture that, it's hard to put weight on it. But keep in mind that even if they can put weight on it, it could still be a fibular fracture. We're not talking about that, but that's just one of the things that I look for in practice. Before we dive into actually the imaging and the treatment, let's go through a word from our sponsor.
Can't get enough of the information you hear on our podcast? You will absolutely love our platform. ChiroUp helps thousands of chiropractors across the globe simplify the way they practice using our online evidence-based software. It's your one-stop shop for powerful clinical research, simplified patient education, and smart practice resources. Visit ChiroUp.com, try it out for free. And if you'd like to subscribe, use referral code podcast15 for 15% 15% off 12 monthly billing cycles. No contract required. Offer valid on new subscriptions only.
All right, thanks. That company sounds pretty cool, that ChiroUp thing. I would definitely take a look at it if I were you.
Oh yeah, I've tried it. I don't know if you have, but it's handy.
It's always good when you can sponsor your own podcast. Diagnostics and differential. Actually, a funny story is Dr. Kuhn, who has been instrumental in one, our education is just as clinicians. However, he also helps out on the board of directors, was actually in my class last weekend. That's kind of, it gives you like that anxious feeling when the people who teach you about a topic and then you turn around and try to teach them, you're like, this isn't going to go very well.
I think they were calling it auditing, actually.
That's probably what it is. However, any kind of imaging of medial tibial stress syndrome is really in the early stages kind of unnecessary. However, with that being said, imaging is appropriate whenever you have any kind of red flags. If you see what Dr. Berlesman was talking about with that focal tenderness, meaning if it's widespread tenderness, you're probably not going to see anything. If it starts to migrate to one spot, there is a possibility of a stress reaction or stress fracture happening there. Any kind of pain at rest is not a good thing. And then, of course, the last one, if a patient is not improving with your trial of care, within that 2 weeks, 4 weeks, they're just not getting better, we really want to go ahead and look for other answers that may be possibly creating that pain. Now, whenever we do have medial tibial stress syndrome, you may, and for good reason, see a periosteal reaction happening at that tibia because it will start to show a callus formation as they start to heal. So that's going to be a good thing if you see that because the person's in a healing process. What do we need to rule out? That's one of the things that we look at orthopedic testing. We get pretty good at finding what is wrong. However, one of the things that is less sexy is what is it not? So what are the other things that could be causing a similar problem in this area?
Yeah, the first one would be, has it advanced along that spectrum and turned into a fracture? And the way that we're going to differentiate that is, where's the pain? That diffuse pain. Let's imagine that you're holding a belt in your hand, and as you're pulling on that belt is the bone. It has nociceptors all over the edge of it. And when I pull on it, it's going to pull on each nociceptor a little, so the pain's going to be diffuse. But now if that belt begins to tear in one spot and starts to rip halfway down, now when I pull on that belt, the nociceptors that are not right on that tear are no longer going to say anything because they're not being stimulated to the point that they're creating pain. So when that pain narrows down to a real small focal spot and starts to last longer in activity, that's a problem. Then eventually it can turn into more of an occult fracture where it's difficult to bear weight. But most of the time it's just going to be more focal pain. That means it's moving in the wrong direction. We'll also think about compartment syndrome, as you had mentioned earlier, an exercise-induced or a chronic exertional compartment syndrome. That has a very similar look, that there's pain. There's probably a little bit more diffuse swelling where the whole compartment is starting to fill up. And when that happens, everything in the compartment gets compressed, including the nerves and vessels. So the one differentiating factor there is we may start to see some paresthesia or weakness or numbness. Those don't typically happen with a shin splint. We'll also think about a peripheral neuropathy. Maybe there's something that's going on with the peripheral nerves, or it's a radiculopathy coming from the lumbar spine. So our dural tension signs would help us to differentiate that. I guess the big question is, once we've said, yes, this is probably a shin splint, it's not progressed to a stress fracture, what do we do? And really, it's trying to decrease the stress below the ability of that bone to heal. If we can get that equation right, think of it as a balance scale. If we can tip it in the right direction, good things will happen. If the patient continues to tip it in the wrong direction, bad things continue to happen. So there's really nothing that works better than relative rest. There's a number of studies that have said the same thing. Unfortunately, this is happening when the kid is putting more stress on it, which is when the kid needs to be using their tibia, not resting it. It's happening during a basketball season, during a volleyball season. And I see it bump up at 2 times. 1, when the weather gets nicer like this, and 2, when kids get indoors. That when we start going indoors with sports in the fall, now you have harder surfaces that you're bounding on, and that puts more stress on it as well. So that's the question, is how do we get the kid to back off enough so that healing can exceed the challenge that they're putting on it? And a lot of times it's not the child, it's the parent, right? Because They know that their parent has the Firecracker 500 tournament this weekend, and they can't miss that tournament because there are pro scouts looking for them, that this is going to be the next phenom. And that's the challenge, is the parent.
You know, it's so interesting when you're saying that. I was just in Austin, Texas for a soccer tournament, and the team, San Diego Surf, I think in that realm or that league or whatever, is just phenomenal. And obviously big area, but I thought to myself, I wonder what repetitive stress injuries affect climates that are good all year round. And I don't know of any research, and if anybody has that, that'd be tremendous. But when we look at seasonal variation in the Midwest, or really anywhere else in the U.S., our kids aren't outside and as active as much, and they do switch seasons more. If it was nice outside and you were playing soccer year long, would we see the same incidence for these repetitive stress injuries? I don't have the answer to that, but just an interesting thing to kind of think about.
That's a great question. Or if you made it through that gauntlet, would you just stay conditioned and not have the same injuries?
Exactly.
We know that when kids specialize in a sport, that they tend to have more injuries just because you're doing the same thing. You know, if you bounce from baseball to soccer to track and field, all of a sudden you're challenging different tissues. So that tends to be better on bodies than one sport. But that would be an interesting study. One thing that we need to do is to determine how do we impact those exact metrics. How do we decrease either the frequency, the intensity, or the duration so that we tip the scale in the right direction. Sometimes that means getting the patient into some non-weight-bearing cross training. Stationary cycling is a lot less stressful on the tibia. Getting in a pool is a whole lot less stressful. We'll try to do things to decrease inflammation. We can use our e-stim machines or some ice, even some home ice massage. And most importantly, probably correcting the things that you talked about early on. You said the torque from having a bad gait or running on a line. People run on a line because they have weak hip abductors, that they're not able to maintain frontal plane alignment of their leg when they land on it where it should, underneath their hip. So they have to throw that peg medial onto the center of the road in order to stand upright. Well, when that happens, they're constantly stretching the gluteus medius, making it even weaker. So when we see that patient, we take them out in the parking lot, have them run. What's happening? Are they toe in? Are they toe out? Are they hyperpronating? Are they running on a line, showing us that, yes, I have weak hip abductors? Changing those is what's going to take the torque off of that bone. Remember, it's not just the muscle that's pulling on it. If you have bony torque, that's going to accelerate an area that has some periosteal irritation and inflammation, and bad things are going to happen. And then finally, stretching out the muscles that are tight, really everything down low, the gastroc and the soleus, the tibialis anterior and posterior muscles. But don't forget the importance of those hip muscles. The hip abductors need to be worked, and they also need to be strengthened.
Yeah, I think one of the things that people try to think about is, should I stretch or should I strengthen? Well, stretching is the beginning of progressive loading. That's just what they can tolerate at that moment. So I'm going to start with stretching them. As soon as they can go through that passive load or active load with stretching, then we start the strengthening, meaning adding extra load. And what you said is exactly right. I mean, these people need to strengthen this tissue. They're trying to strengthen it too fast with going from 0 to 100. However, that tibialis posterior and the hip abductors, or the butt muscles, really need a little bit of work. I can say from an opinion, that's 2 opinions from today. That's kind of, I'm going to roll here.
8:42 in the morning.
I know. I love the double posterior lunge and the semi-stiff deadlift in ChiroUp. Those are my favorite. And really, I like the semi-stiff deadlift the best, which is kind of like a Roman deadlift or a straight leg deadlift, because it forces some balance. So these people, when you run, you're running on 1 foot at a time. You can't run on 2 feet at a time. That'd be kind of silly. Would be standing. It wouldn't be running at all.
You have data to support.
However, it forces them to get a little bit of balance and start to use their feet. And that's where I think a lot of this problem happens. If you look at someone who's running and they don't use their feet, those are people that they hit the ground and they pick their whole foot up at one time and they don't use that foot to propel themselves forward. So that exercise will help with balance and strengthening. Now, as a chiropractor, I love manipulation, and I think this is one of these areas that manipulation, as far as the tibia and fibula, we can't do a lot with. However, the spine, the sacroiliac joint, the pelvis, absolutely, but also do the lower extremity. You have that rocker system in your foot, you have the subtalar joint, you have the ankle mortise joint, you have the midfoot. All those joints need to move properly. In fact, you need that first ray, that first toe, to actually dorsiflex 70 degrees to actually start that windlass mechanism. So taking a look into the foot, making sure all those joints are moving fine. And I'm not a huge orthotic person for everyone. However, in the right situation, arch supports have some good research to support that, hey, we can actually decrease the load on the foot when we have fallen arches, or when we put an orthotic in a person with fallen arches. So if you're looking to help take a little bit of load away from this person, orthotics can help. From the research, we don't see that much of a difference between custom and prefabricated orthotics. I do think for certain situations we do need custom orthotics. However, for this one where we're treating something else, may not be necessary. I think that this is one of those things that goes into the terrible P's. Post-surgical patients, pregnancy patients, and parents are the worst patients to treat. So that third P are the parents, and that's where things kind of get hairy. I mean, we can get a kid out of pain, but we're also trying to convince the parent that we know what we're doing, we know the right diagnosis, and that taking their kid out of their sport is a great idea because it's going to help them get them back into their sport faster. So it brings up the next point is, how do we not only rest them and take them through some low-tech rehab, but how can we accelerate healing and get these kids back to their sport?
Yeah, there's outside of the primary thing that you just talked about, there are a couple of things that we could add to it. There's some research to say that compressive bracing or taping or sleeves do enhance bone remodeling, and so a lot of providers will prescribe those things. There's not conclusive evidence to say that works. Now, what's important to recognize is when something says it's not completely supported by the literature, that doesn't mean it doesn't work. It means that there's no literature to support it at this point in time. But there is literature to say that probably provides symptomatic, if not some real physical benefits. Same thing that you had talked about with the arch supports in the feet. Anytime that the arch of the foot falls, it's going to cause internal rotation of the tibia, which means torque. Things that are becoming stress fractures don't like torque. So if we can support the arches with either the orthotics or an insert, or some anti-pronation taping, so that's certainly something else that's shown to be beneficial. The other things that the literature says may work: dry needling, PRP injections, prolotherapy, and even acupuncture. So there's a whole slew of things that say yes, something works, and really anything that can tip the scale in the right direction and remove a little bit of stress of things that are going in the wrong direction is going to get the patient moving in the way that they need to go, so that they can continue to challenge that. And then once the bone is remodeled, then we can start to challenge them by increasing their activity. But there's probably a time frame that this needs to slow down. This is certainly not a diagnosis of broken dreams, but it is a diagnosis of potentially postponed dreams. We might need to slow you down a little bit.
Yeah, I found two articles, one being compression garments, which you just talked about, and I think that's a good, or I should say, it's an okay strategy short term. But unfortunately, whenever you have compression on the tissue, we could be creating a compartment syndrome if we try to take that and turn it into a long-term solution. The other one was extracorporeal shockwave therapy. That may also speed up recovery time, just getting that tissue to heal faster. Unfortunately, surgical intervention is not great. We know that's when you have to start taking and cutting that fascia, posterior fasciotomy. It's really indicated, it's only for those people that start to get those neurovascular symptoms or signs, I should say. Well, that is it for medial tibial stress syndrome, and I think that before we close this one up, I think that the most exciting part of this podcast is to talk about none other than
You?
Well, we can do that too. I don't think many people care, but
We just saw a big drop off.
yeah, sorry about that.
Let's dive into the EHR. That one of the most exciting things is we're using our new SOAP note system in the office, and we're the alpha testers of this process.
We're the grunts, is what we are.
Yeah. We the other day, I looked at my notes and I'm like, I get to do an initial report, and it brought a smile to my face. And I thought, that's never happened in my years of practice. I've never thought, oh man, I get to do a note. But it was awesome that the notes are speedy. So that's number one, is that we're excited about providing you with a product that improves your workflow to dramatically speed your most challenging task with a meaningful note that can really be done in seconds, even an initial visit note. Also to enhance your billing, that everything is integrated in the product, that billing and scheduling and SOAP note and charting and reporting, none of those were afterthoughts. This was all built with the process of how do we make this one seamless system to reduce data entry. And most importantly, I think that we're not building an enhanced EHR. Yes, chiropractors need a good EHR, but we're building an enhanced profession. That by collecting homogeneous data, by fueling the data lake in our profession, being able to prove our differences and our effectiveness and our superiority with real-time data and sharing those best practices with the profession and with each other, there's not another profession that's going to beat us. That the future is truly bright. We're proud to be part of that journey. We're proud to have you on that journey, and we can't wait to give you the keys to your new EHR this summer.
Yeah, it's been fun. Now, doing double notes right now has not been my the most fun. However, we're doing less and less notes in the last system and almost all of our notes now in the new system. One, it just saves time. But two, there's never been a note that puts a smile on my face like you. However, it's easy, it's effective, and it's complete. So pretty cool. If you haven't already, make sure you follow the Mic'd Up with ChiroUp podcast. And whenever you're listening, leave us a review. I want to thank Dr. Sally for the last review. We appreciate that. And I want to thank, I think I mentioned it earlier, Dr. Thompson for giving us the content for this actual episode. So we'd love to hear your biggest takeaways from this episode and hope you'll give us a listen next time.
Hey, thanks for listening. To access more information, visit ChiroUp.com. You can sign up for a 14-day trial. Use referral code PODCAST15 for a special discount after your trial. Offer valid on new subscriptions only.